moderate
Okay.
the session. Okay.
Okay.
So
Okay.
Monica, it's live. You can go live.
Good evening, everyone. Good evening, delegates. Good evening, speaker. I welcome you all on behalf of Shield Healthcare. I'm Dr. Monica. And today's topic is Dysmenorrhea by Dr. Indu Chauhan. MBBS, University of Rajasthan, Udaipur, MS OBG and Gynecology from University of Rajasthan, Jaipur, Diploma course in Obstetric Ultrasound, 1995, certificate course in laparoscopic surgery, advanced course in IVF and ART, 2010 Boston IVF Center, Foxy training course on advanced infertility, life member IMA, life member Foxy, president of Jamshedpur Obstetrics and Gynecology Society from 2016 to 2018, and experience, she worked even in Tata Tin Plate Hospital, Jamshedpur from 1989 to 2007 as specialist OBG and gynecology, and also working as a consultant and gynecologist and endoscopic surgeon at Vardhan Maternity and Nursing Home, Jamshedpur since 2007. Consultant IVF specialist at Vardhan IVF Center, Jamshedpur. I welcome you, ma'am, and I hand over the session to you.
Ma'am, it's a pleasure to have you on our platform for today's webinar, and we will hand over the session to you. So let me stop sharing screen.
Good evening, everyone. Yes. Good evening, all delegates. It's my pleasure to be again with you and sharing my thoughts on a very interesting topic that is, let me share my screen. Yes, that is, that is dysmenorrhea and its management. Dysmenorrhea is a very, am I audible?
Yes, ma'am.
Hello.
Yes, ma'am. You are audible, and you can make this slide mode.
Yeah. Slideshow. Yes. So today we are going to discuss. I'm going to talk and I'm going to discuss about the dysmenorrhea and its management. It's a very common complaint in the gynae OPD, especially with young adolescent girls. They are actually very, tired of having this pain every month, and rather sometimes some of the girls, they scare so much, they dread just to have periods, thinking about the pain what they will experience. So we should have proper scientific approach towards this problem, which is a regular problem with the females. Now, what is menstruation and menstrual cycle? Menstruation is the monthly shedding of the lining of the uterus. Menstruation is also known by various terms like menses, menstrual periods, or simple periods. This cycle is part of reproductive system and body is prepared for egg production and possible pregnancy. So once the egg is produced, if this egg is fertilized and pregnancy is there, the period stops. And if this, which is 48 hours, is the life of an egg.
Hello, ma'am. Surya?
The girl has had a menses on day 1 of the month. Again, she'll have on day 24th or 25th, which they say that they have got cycle twice a month. So we have to make them understand that the cycle length of 21 to 35 days is a normal cycle length. So they should not be worried about it. If it is less than 21 days, that means if the menses are coming within 18-20 days, then it is worrisome. If it is coming beyond 35 days, that means 37, 38 or 40 days cycle, then they should think about it. But if it is the cycle is regular, even with the 40 days, the girl should not be much concerned about her irregularity in menstruation. So once these girls are coming to the gynae OPD, we make them understand that what is a normal cycle length and what should they consider normal and what should they consider abnormal. This is a very, very important task of a clinician to make these young girls understand about their menstrual pattern. Now, what are the phases of menstrual cycle? The day count of menstrual cycle begins on the first day of menstruation, when blood starts to come out of vagina. The length of menstrual cycle I've already told is 28 days. Now, the menstrual cycle is divided into 4 phases. Menstrual phase, that is from day 1 to 5. Average cycle is from day 3 to 5 days of days is the average menstrual blood flow. Follicular phase from day 1 to day 13. Ovulation phase day 14th and luteal phase day 15th to day 28. This is in a 28 days cycle. If a cycle which is shortened, the first phase, that is a follicular phase, it is shortened. If the cycle is prolonged, that means if the female has got a cycle of 35 days, the follicular phase is increased or it is lengthened. Luteal phase, that is after ovulation, it is more or less constant. Now, what are the phases of menstrual cycle? I told you that follicular phase, ovulatory phase, and luteal phase. Now, how this happens? The FSH, follicular stimulating hormone, which is secreted by pituitary, it helps in growth of follicles to produce eggs. The excessive secretion of LHN in the mid-cycle helps in releasing egg from follicle. So what happens? The anterior pituitary starts secreting follicular stimulating hormone, which acts on the follicles, which are there's a series of follicles which starts developing, but one follicle becomes prominent and it starts growing to produce egg. Now, in the mid-cycle, there is a sudden increase in the secretion of luteinizing hormone, which is known as LH surge. Now, this LH surge helps in releasing the egg from follicle. Once the ovulation occurs, this follicle, which is known as corpus luteum, and this corpus luteum starts secreting progesterone. Once the follicle starts growing, there is a secretion of estrogen. Normally, a good follicle should produce at least 200 picogram of estrogen just before the ovulation. So when we are trying to know about the ovulation, or when we are doing ovulation studies, sometimes the follicles which we see are not good follicles and they don't produce good eggs. So how to judge about it? We can get the estrogen level done in the mid-cycle just before ovulation, and per follicle, if the estrogen level is 200 picogram per ml, it indicates that this is a good follicle and it's going to produce a good egg. After ovulation, the progesterone level starts increasing. Now, progesterone levels gradually increase till the time of menstruation. Just before menstruation, there is a sudden fall of progesterone hormone because the corpus luteum, its function starts deteriorating. So once there is a sudden fall of progesterone, this is the time to start menstruation. So in nutshell, this is the menstrual cycle. Now, what is dysmenorrhea? Dysmenorrhea originally is a Greek word. Dysmenorrhea defined as a painful menstrual cramps of uterine origin. In the most common, it is one of the most common gynecological condition amongst the women of reproductive age group. Clinically, it refers to
Hello, ma'am. Hello.
Is there any problem? Hello?
Yes, ma'am. Yes, ma'am.
Is
Now
there
we
any
can hear you.
problem?
No,
Yes,
ma'am.
ma'am.
Now we can hear you.
Are you not able to hear me?
Yes, ma'am. Yes, ma'am.
Okay, because in my place there is some problem because there's a lot weather is not very good, some
Okay.
instability in the network connection.
Okay,
So
ma'am. Okay.
it's popping. Yeah. So my network connection is little unstable. But if you are not able to hear me, please interrupt me and let me know.
Ma'am, now it is fine, ma'am.
Okay.
You can continue.
Okay. So if the pain is severe enough to prevent the day-to-day activity of a female, and if she needs to take medication, it is known as dysmenorrhea. The little slight pain, which is just in the form of discomfort, we don't label it as as dysmenorrhea. When we are talking about dysmenorrhea, we are talking about the pain which actually disrupts the day-to-day activity of a female. Now, what kind of pain it is? The pain is lower abdominal pain, sometimes associated with back pain, or sometimes only back pain, pain with cramps in the abdomen, and pain, sometimes pain with leg cramps also. It usually occurs in adolescent age group. Initially, once the patient starts having periods, that is menarche. Initially, after menarche, the patient may not experience any pain. The pain starts occurring after 6 to 24 months of menarche. Why so? Because initial periods, initial cycles in a girl is most of the time anovulatory cycles. And dysmenorrhea, if it is primary dysmenorrhea, is mostly associated with ovulatory cycles, because there is a cyclical production of estrogen, progesterone, and prostaglandins, which will come later. The onset of pain usually has a clear and predictable pattern. Pain begins just before and at the start of menstruation. Pain is most severe during the first or second day of menstruation. So mind it that pain begins just before and at the start of menstruation. And pain is most severe during the first or second day of menstruation. Why I am emphasizing these two words, that it starts just before or at the time of menstruation, and it persists on the first or second day, because there is a difference in the secondary dysmenorrhea and primary dysmenorrhea, especially the pattern of the pain. In endometriosis, when the patient has severe dysmenorrhea, the pain starts much before the beginning of menstruation, and it lasts till the menstruation finishes, or sometimes even 1 or 2 days after the menstruation. So this is a very clear, we can clinch that this is a primary dysmenorrhea, or this is a secondary dysmenorrhea. Even a young girl who is coming with severe dysmenorrhea may have endometriosis, and it should not be neglected just by thinking that it's a simple primary dysmenorrhea. Now, what can be the additional symptoms during dysmenorrhea or during menstruation? Nausea, vomiting. It's a very, very common symptom. Any pain which is beyond tolerance leads to nausea and vomiting. Diarrhea or constipation. This is again a very common symptom during menstruation. Few patients, few females, they experience diarrhea, whereas few females, they experience constipation during menstruation or just before menstruation. Headache and dizziness, fatigue, insomnia. There's a disturbance in sleep pattern. Few females, they experience disturbed sleep pattern just before menstruation or even during menstruation. Feeling bloated, which is more common just before menstruation. Breast tenderness, mood changes, loss of libido. This is not exactly dysmenorrhea. These are symptoms like bloated, breast tenderness, mood changes, loss of libido. If we include all these symptoms are more common with premenstrual tension, premenstrual syndrome. So here we are talking mainly about the dysmenorrhea. Now, what is the impact of dysmenorrhea? The impact of dysmenorrhea in young girls is the absenteeism at school. They are not able to go to school. Loss of work days, work absenteeism, decreased work efficiency, decreased focus on studies. If a female, she's working, she has got less. Definitely, if she has got pain, she's in an agony, the work efficiency decreases. Similarly, the girls who are studying, their focus on studies decreases due to this agonizing pain. Reduced sleep quality in physical activity due to pain. Anxiety, stress when there is pain. It affects the quality of life and performance in daily life activities in women. The rates of absenteeism in these women range from 34 to 50%, losing 1 to 2 working days per month, which is not less. If we think that if a female need to take leave from the work 1 or 2 days per month, nobody will allow her to take leave. So this is a very agonizing problem, in which has to be addressed so that she doesn't lose her working hours and working days. This absenteeism amounts to loss of approximately 600 million working hours, or up to $2 billion annually in the USA. So this problem we say it's dysmenorrhea, is not a small problem. It's a really big problem which we have to address. Now, what is the prevalence of dysmenorrhea? It's varies between 45 to 95% of menstruating women. 95%. So just think about the prevalence of dysmenorrhea in female population of reproductive age group, especially in young girls, in adolescent age group. If 95% of females are experiencing the pain during menstruation, think about it, that how distressful it is. Severe primary dysmenorrhea estimated to affect 25% of women. As such, dysmenorrhea appears to be the most common gynecological disorder in women, irrespective of the nationality and age. Now, primary dysmenorrhea, as I told you, it's a common menstrual cramps without pathological causes. In primary dysmenorrhea, there has to be no pathology which can lead to pain. Whereas in secondary dysmenorrhea, there is a definitive pathology which is responsible for the pain during menstruation. This is the difference between primary dysmenorrhea and secondary dysmenorrhea. In primary dysmenorrhea, there is no etiology which is leading to pain during menstruation. So it is a simple muscular menstrual cramps. Whereas in secondary dysmenorrhea, there is a definitive pathology which is like uterine fibroids, pelvic inflammatory disease, endometriosis, infections, tumors or polyps in the pelvic cavity. So if a female comes with a complaint of dysmenorrhea, if she is young, in the adolescent age group, if she is nulliparous, the first diagnosis is primary dysmenorrhea. And then we should take a detailed history that when she starts having pain, how many days she has pain, and how and when her pain subsides. If it's a clear cut it indicates that there's a primary dysmenorrhea, there is no additional pathology. But if the symptoms are suggestive of secondary dysmenorrhea, the patient or the female should be thoroughly investigated to find out a cause of pain. Many a times when we do ultrasound, we see uterine fibroid, endometriosis, and many a times in many patients, I think all gynecologists must have experienced that we diagnose very advanced endometriosis in young adolescent girls, thinking it initially to be a primary dysmenorrhea. So it's a primary neglected dysmenorrhea, which leads to a very advanced stages of endometriosis, big chocolate cysts. So any pain, any dysmenorrhea, a detailed history should be taken. And if it is suggestive of any kind of secondary dysmenorrhea, we should be investigating these females. And nowadays, the ultrasound is readily available in every nook and corner of the country and town. So we should get ultrasound done if there's slightest of doubt about the patient non-having primary dysmenorrhea or the patient having secondary dysmenorrhea. Now, what are the causes of primary dysmenorrhea? Now, we are mainly discussing here the causes of dysmenorrhea per se, primary dysmenorrhea. What happens? Why there is a pain during menstruation? There is a forceful and excessive uterine contractility during menstruation. If there is no pain during menstruation, the uterine pressure, it is measured, is nearly 10 millimeter of mercury. Whereas the woman who has pain, the uterine pressure is more than 120 millimeter of mercury, which is more or less like labor pain. Increased number of contraction per 10 minutes. That is 4 to 5 and non-rhythmic uterine contraction in women with pain. Now, these uterine contraction, which are non-rhythmic, more than 4 to 5 per 10 minutes, they lead to pain. The females who have history of passage of clots, they experience pain more than the patients who don't pass clots. Now, what leads to the pain? The excessive synthesis of prostaglandin leads to this kind of pain. Disturbance and decrease in uterine blood supply. There's a reduced uterine blood flow during contraction, which leading to hypoxia to the uterine muscle and thus causing pain in turn. Now, what is the role of prostaglandins in the causation of pain? Prostaglandins are lipid compounds present in cell membranes. Prostaglandins are produced from arachidonic acid, polyunsaturated fatty acids by the enzyme phospholipase A2. Prostaglandin can cause uterine contraction. We all know that for the induction of labor, we use nowadays prostaglandin. Prostaglandins play a major role in dysmenorrhea. Excessive prostaglandin concentration before menstruation leads to pain during menstruation. Now, this prostaglandin causes abnormal or forceful contractile activity of the uterus, narrowing of the blood vessels supplying the uterus, which leads to hypoxia of the uterus. And because there is an increase, because of higher concentration of prostaglandins, there is increased sensitivity of the nerve endings, so that the experience of pain is more. Now, how to measure period pain and other symptoms? The very important thing that we don't have any scale by which we can measure that how much pain this patient is having, because pain sensitivity is again different in different set of people. So now we want to know that whether this patient, whatever patient is complaining about the pain, is it genuinely a severe dysmenorrhea, mild dysmenorrhea, or moderate dysmenorrhea? So we have to devise a menstrual symptom questionnaire, and we should judge on that particular questionnaire that how much pain this patient is having. This is a very busy slide. I think it's nobody will be able to read this slide. So there are various questionnaire, and this questionnaire is given to the females, and they will answer this question in the never, rarely, sometimes, often, and always. Like, I feel irritable, easily agitated, and I'm impatient a few days before my period. I have cramps that begins on the first day of my period. So the female will answer in the no, rarely, sometimes, often, always. So there's kind of 25 questions are there. And when this questionnaire is filled, the pain scale is 0 to 10, because every answer has got numbers 1, 2, 3, 4, 5. So on pain scale 1 to 10, if there is a 0, there's no pain. If it comes 10, it's the worst pain possible. So that's how we can judge. So every time we cannot get the patients to fill this 25 question questionnaire, at least few questions we can ask from the females that, are you really so much disturbed that you are not able to go to your work? Do you have vomiting? Do you have bloating? So there are certain symptoms which indicates that yes, the pain is severe enough to label it as a dysmenorrhea, especially vomiting, diarrhea, constipation, backache, leg cramps. So these are conditions, they indicate that this problem needs to be addressed. Now, there is the data collected from 1,000 healthy females aged 11 to 28 years. The data collected by self-reporting questionnaire and pain intensity assessed by using the numerical rating scale, which I was showing you earlier. So pain intensity was moderate to severe in 47% moderate, and in 22% there was the pain intensity was severe. And more than 70% patient, they experience menstrual pain every month. The pain length was 1 to 2 days. In 30%, in more than 40% of patients, the pain length was 1 to 2 days. In 30% of females, the pain length was 1 day. Now, frequency of dysmenorrhea, in 68% of females, the every month pain occurs, whereas in 20% of females it occurs less frequently. Absenteeism and other questionnaire was also there. The taking of analgesic, almost 30% of females, they take analgesic every month, whereas 70% females, they don't take analgesics, but they feel bad about the pain. They feel distressed about the pain. But why they don't take analgesics? Because as a gynecologist, I'll tell you, they have got feeling that if they take analgesics, it's not good for their health. So they rather keep on suffering, keep on tolerating the pain instead of taking analgesics. Now, as I was talking, what is the pathophysiology of dysmenorrhea? This is the excess production of prostaglandins. The prostaglandins, they cause forceful uterine contraction, which leads to the decreased blood flow, decreased blood supply to the uterine musculature, and ischemia further increases the pain. Now, how to diagnose? I've already discussed you for diagnosis that you should take a proper medical history, do proper physical examination. If patient is unmarried, nulliparous, we cannot do internal examination. So that if you feel that pain is severe enough, should go and go for ultrasonography. In married patients, we can do simple pelvic examinations, and many times we are able to diagnose many pathologies by simple bimanual examination. Even if it is not conclusive, the ultrasonography is a gold standard method to diagnose any pelvic pathology. Now, what is the treatment for dysmenorrhea? The first line therapy is mefenamic acid. This is the most commonly prescribed drug. And the second line is oral contraceptive pills. As I told you earlier, that most of the cycles, in most patients, the ovulatory cycles are painful, whereas anovulatory cycles are mostly not painful. So if the patient doesn't get relief with mefenamic acid in the first line of therapy, that is by NSAIDs, the second line of therapy is oral contraceptive pills, at least to give few months of pain-free cycles to that particular female who is in too much of distress, especially during examination, going out, when the girls are going to change the place, like going for college, going in the hostel. That time they don't want to experience this kind of pain while they are getting settled at a new place. That time oral contraceptive pills can be prescribed. Now, what is the action of any painkiller? That is that they mainly NSAIDs, they act on arachidonic acid pathway. There are two types of prostaglandins, pro-inflammatory and anti-inflammatory prostaglandins. So during menstrual pain, during dysmenorrhea, the pro-inflammatory prostaglandins, PGE2, thromboxane, these are increased in concentration, which leads to pain that I have already explained. Now, what is the drawbacks of existing NSAIDs and oral contraceptive pills? When we have got such a simple answer to this pain, that take NSAIDs and or take oral contraceptive pills and remain pain-free. Is it so simple? No, it's not that simple, because these drugs have got their own side effect, their own disadvantages. What is the side effect of NSAIDs? Leads to gastrointestinal side effects, nausea, vomiting, diarrhea, stomach aches, we all know. Serious side effects of NSAIDs are gastritis, stomach ulcers, and even sometimes GI bleed also. The other side effects are headaches, drowsiness, dizziness. Allergic reactions. NSAIDs are contraindicated in renal insufficiency, peptic ulcer disease, gastritis, GI bleeding, or hypersensitivity. Overall failure rate of NSAID is approximately 20 to 25%. Long-term use is discouraged. OC pills are actually not approved for dysmenorrhea for a long duration, because this can cause to thromboembolism. This is not a first line of treatment. This is only an emergency measure which is to be taken for a very short period of time. So what to do? What can we do when we have got a problem which is so prevalent, so regular, so every month it is coming, and now we have got medicines which has got side effects which we cannot give, like OC pills and NSAIDs, which has got a lot of side effects, and this is a regular problem. There are other approaches to treat dysmenorrhea. We should resort to some other measures, which is acupuncture, acupressure, heating pads for cramps, extra rest or sleep, physical exercise, meditation, some homemade remedies like ginger root, turmeric extract, pineapple extract, fennel extract, rosemary extract, salt water, calcium and vitamin D supplements. So there are various approaches which are used to reduce the pain during the menstruation. But we don't have any proper medication, proper answer to treat our patients who are in the distress. So this is a new medicine which has been launched first time in India, that is Dismajestic. Now, what this Dismajestic does it is an antispasmodic and anti-inflammatory and analgesic. What does it contain? It contains bromelain. Now, from where does this bromelain come from? This comes from pineapple juice and pineapple stems. What is the mechanism of action? Of bromelain? It increases the anti-inflammatory prostaglandins and decreases the pro-inflammatory prostaglandin, and it leads to the has got antispasmodic effect due to the reduction in pro-inflammatory prostaglandins and increase in anti-inflammatory prostaglandin by the modulation of TN alpha and interleukin. So there was a study which was conducted in 39 female students aged 15 to 17 years. They received pineapple juice and placebo. Treatment given for 3 days for 3 cycles. Now, before treatment pain score, after treatment pain score, and p-value. When the pineapple juice was given, the before treatment pain score was 5.25, whereas in placebo group it was 5.44. After treatment, there was no difference in placebo group, whereas in pineapple juice group it was reduced to half, 2.25. So the p-value is less than 0.001. It indicates this is a very good medicine to treat dysmenorrhea, and this was published in Indonesian Journal of Medicine in 2019. Rosemary extract, it has got the active constituent, active ingredient, which is known as ursolic acid. Now, what this ursolic acid does? Again, it has got inhibitory action on COX-2 enzyme. Inhibitors of COX-2 enzyme can reduce the production of prostaglandin. We know the main culprit is prostaglandin. So anything which will reduce the production of pro-inflammatory prostaglandin will reduce the pain, and any chemical or any ingredient which will increase the anti-inflammatory prostaglandins will reduce the pain. Mefenamic acid has a similar mechanism of action to reduce pain. By reducing prostaglandin, it can show anti-spasmodic action and analgesic action. Rosemary extract can reduce the production of IL-2, interleukin beta, TNF alpha, thus having anti-inflammatory effect. TNF is a tumor necrosis factor alpha. So it reduces the production of these prostaglandins and causes anti-inflammatory effect. I'm not going into the detail of how this rosemary extract, where it acts at the arachidonic level. After arachidonic acid to prostaglandin G2 synthesis, then prosta G2 to prosta H2, this pathway is blocked, therefore the pain is less. So pro-inflammatory prostaglandin product is reduced. So the pain is reduced. The comparison of ursolic acid versus mefenamic acid. The study was conducted and it was published in Iranian Journal of Nursing and Midwifery in 2019, where 82 women from the age group of 18 to 25 years were enrolled. The women divided into 2 groups. One got ursolic acid and one got mefenamic acid. Now, the pain was measured on visual analog scale using 0 to 100. Pain score before treatment, ursolic acid group 40.39, whereas in mefenamic group it was 46.75. Pain score mean after treatment it was 23.57, and in mefenamic acid it was 28.29 on the visual analog scale, that is 0 to 100. So what does it prove? It proves that ursolic acid is as effective as mefenamic acid without any side effect. Curcumin. We all know, especially in our Indian cooking, we use a lot of curcumin. Turmeric is derived from curcuma longa and includes curcuminoids such as curcumin, dimethoxycurcumin and bis-dimethoxycurcumin. In our old, we generally hear from in our families that for any kind of pain, this curcumin is very good. It's a member of some regional diets in numerous Indian and Asian cultures. So now it is a scientifically proved fact that how curcumin reduces the pain. Again, curcumin works by modulating the inflammatory response by regulating the activity of cyclooxygenase 2, COX2, lipoxygenase, and nitrite oxygenase, which reduces the pain, so that it will reduce or even inhibit uterine contractions. The mechanism of blocking uterine contraction through curcumin is by reducing the influx of calcium ions into the calcium canal in uterine epithelial cells. So once the influx of calcium ion into the muscle is reduced, there is a reduced muscle contraction, and which reduces the pain. It has got anti-inflammatory actions, and curcumin is frequently used with bromelain to improve absorption. We all know that in India, this curcumin is given in most of the cultures. This curcumin is given after delivery to reduce pain and as an anti-inflammatory. So now it is scientifically proved. Whatever we were using, or our old people were using, it has some scientific basis. Again, the mechanism of action of curcumin is similar as the rosemary extract. So this is a study which was published in Journal of Biomedical and Pharmacology in 2020. In this study, 32 young women with primary dysmenorrhea were enrolled. Women were divided into two groups: the curcumin drink, homemade, and drink by researchers. Women had the drinks from the first day of menstruation until the third day, twice a day. So curcumin drink, homemade, curcumin drink by the researchers, and baseline the pain was 5.5 and 6. Post treatment, there was no pain in both the groups. So it is proved that curcumin drink reduces the pain of menstruation. The fenchon and anethol. From where does we get these things? This two ingredients we get from fennel seeds, which is a very commonly available in all Indian households. Now, again, what is the mechanism of action of fennel extract? The mechanism of action of fennel is similar to diclofenac. Fencho as the main components of fennel that inhibits prostaglandin E2 and reduces uterine contraction. It acts as an antispasmodic. Anethol as the main component of fennel has the similar structure to dopamine, which binds to dopamine receptors and decreases the pain. So it acts as an analgesic. The anti-inflammatory effect of fennel is due to inhibition of histamines H1, H2 receptors, antihistamine for cough and cold. I would like to mention here that in Dadi maa ke nuske jisko bola jata hai, in our families, when a small child gets abdominal pain, the mothers generally they give the fennel extract to the child, and the child really gets relief from this pain. So this is now would like to the effectiveness of fenchon versus mefenamic acid. 100% women had pain before starting the treatment. Women received either fenchon or mefenamic acid. Pain intensity. The percentage of women reported no pain after treatment. In Pancha group, it was 80%, whereas in mefenamic, it was 73%. So the result is the Fencho is as effective as mefenamic acid. And this was published in 2003 in International Journal of Gynecology and Obstetrics. In 2003, this paper was published. Now, this is a study which was done. It was a multi-center, single-arm, open-label study. 120 women with moderate to severe dysmorphic pain were enrolled. This study was done by Shield, I hope. Dismajestic for 2 consecutive cycles from day 1 to day 3 of menstruation. Dose was twice a day. Now, what is the result? Pain score and pain duration. Baseline pain score, cycle 1 after treatment pain, cycle 2 after treatment pain, and what was the p-value? The baseline pain relief was approximately within 32 minutes. The pain relief occurs within 32 minutes of taking the Dismajestic tablet. Other menstrual symptoms, there was significant reduction in other menstrual symptoms also, that means pain, cramps, and even the menstrual flow. No side effects was observed during the study. Now, what is the secondary dysmenorrhea? Basically, here I would like to touch upon secondary dysmenorrhea also, because it is very important while we are thinking about primary dysmenorrhea as a normal physiological phenomena, which is really troublesome. So we want to handle this trouble just by giving simple medications. But sometimes we miss out on diagnosis of secondary dysmenorrheas or some pelvic pathology, thinking it to be a primary dysmenorrhea, and which can lead to, some problems which sometimes become very harmful for the reproductive uh, this thing of the status of the female. Now, the secondary dysmenorrhea is basically due to an underlying disease of pelvic organs, which are mainly endometriosis, congenital and anatomic abnormalities, sexually transmitted diseases, pelvic inflammatory disease, adenomyosis, uterine leiomyoma, and cervical stenosis. Here, most important is, which if missed, leads to problem in the future life, is endometriosis, adenomyosis, and uterine leiomyoma. Sometimes there's non-gynecological reasons also, which leads to symptoms similar to secondary dysmenorrhea, like high tone pelvic floor dysfunction, irritable bowel syndrome, bladder pain syndrome, pelvic adhesions. This is very, very important. Post pelvic inflammatory disease, sometimes pelvic inflammation leads to pelvic adhesions, and it leads to secondary dysmenorrhea because there is a pelvic congestion at the time of menstruation, which leads to pain, and this pain lasts for throughout menstrual cycle. This is the photo of endometriosis. If it's missed, it can really compromise the reproductive career of a female. Now, diagnosis of secondary dysmenorrhea is very important. The history is very important. The onset of symptoms several years after menarche. Most of the time, the secondary dysmenorrhea starts after several years after menarche. Recurrent pelvic history of recurrent pelvic infection, fever and vaginal discharge, IUCD insertion, any pelvic surgery, heavy periods like heavy menorrhagia, which is an indicative for adenomyosis, endometrial polyp, fibroid, infertility and dyspareunia, endometriosis. Now, physical examination, bimanual examination, many a times points towards pelvic diseases. If bimanual examination is not possible, patient is unmarried, ultrasound is a gold standard to diagnose all these problems. I will not go into the much detail of secondary dysmenorrhea, just to touch upon ultrasound, transvaginal ultrasound, pelvic masses, uterine fibroids, pelvic abscesses, and adenomyosis can be diagnosed. Laparoscopy, if a patient is, has got really bad secondary dysmenorrhea, her lifestyle has everything is compromised, or she's unable to conceive, she has got a history of infertility, laparoscopy helps in diagnosis, and both in diagnosis of amenorrhea, secondary cause of secondary amenorrhea, and sometimes it helps in treating also. Like if there are pelvic adhesions, it can be simultaneously treated while doing laparoscopy. Management of endometriosis, chocolate cysts, that can be operated upon by laparoscopy. Hysteroscopy, if there is suspicion of any intrauterine pathology like endometrial polyp, then hysteroscopy helps in diagnosing as well as treating the cause of the secondary dysmenorrhea. Now, if we want to differentiate between primary and secondary dysmenorrhea, in nutshell, shortly, primary dysmenorrhea starts shortly after menarche, whereas secondary dysmenorrhea usually starts after 5 years of menstruation. Time during ovulatory cycle and menses only, whereas secondary dysmenorrhea may not be necessarily associated with menses. Most of the time, it lasts for all the days of menstruation, and even sometimes 2 to 3 days before menstruation, 2 to 3 after menstruation. Age group is mostly 15 to 25 years, whereas in secondary, 30 to 45 years, the most common age group. Duration, 8 to 72 hours during menses, duration of pain. Symptoms are more or less similar, though in secondary dysmenorrhea, the symptoms are much more graver and severe. Now, very important, the primary dysmenorrhea gradually improves over time, and generally it improves after first childbirth, provided it is a normal vaginal delivery. Whereas secondary dysmenorrhea becomes worse over time. Sexual activity improves primary amenorrhea, whereas no change in the pain intensity of secondary dysmenorrhea due to sexual activity. Oh, now, one word about premenstrual syndrome also. The dysmenorrhea should not be confused with PMS. Premenstrual symptoms resolve shortly after menstrual flow has begun, unlike dysmenorrhea, which continues for up to 72 hours. Now, what is premenstrual syndrome? A group of physical, emotional, and behavioral symptoms that occur in second half of the menstrual cycle, often interfere with work and day-to-day activities. Here, period of symptoms entirely free becomes free at the start of menstruation. So, in primary dysmenorrhea, generally the symptom starts with menstruation and remains for 8 to 72 hours. But whereas in premenstrual syndrome, the symptoms are severe during premenstrual period, and immediately patient starts feeling better with the onset of menstruation. The symptoms are bloated, weight gain, edema, breast pain, tenderness, hot flashes, pelvic pain, joint or muscle pain, irritability, aggression, tension, anxiety, depression. Now, what causes this premenstrual syndrome? This is where various theories are put forward: vitamin B6 deficiency, and sometimes it is considered to be a psychological problem. Now, in PMS, one very important thing is ovulation and progesterone production are important in this syndrome, and the drugs that inhibit ovulation relieves the PMS symptoms. The management is counseling for exercise, lifestyle modification, exercise, dietary modification. 20 to 30 minutes of exercise increases the endorphin in the brain, distract the woman from her emotions, and she feels better. And if the symptoms are too severe, like bloating, sometimes diuretics has to be given, antiprostaglandins from cramp pains, breast tenderness, bromocriptine, danazol, bromocriptine is given. For ovulation suppression, if PMS is so severe that patient is not able to tolerate the symptoms, she feels too irritable, too emotionally drained out, then we have to give sometimes ovulation suppression in the form of OCPs, danazol, medroxyprogesterone, acetate continuously, and primrose oil. But so what we were talking about dysmenorrhea, what is the management pathway for dysmenorrhea? Suspecting dysmenorrhea, if there is no pelvic pathology suspected, then there is a primary dysmenorrhea. Treatment is recommended. Initially, non-pharmacological treatment in the form of lifestyle changes, exercise, hot water bag, some other kind of thing. If it is not effective, NSAIDs, not effective, hormonal contraception. Whereas if pelvic pathology is suspected, secondary dysmenorrhea is suspected, proper diagnosis has to be made that what is the cause of dysmenorrhea, and that has to be treated. So the take-home message for the dysmenorrhea is very important thing that it is a very, very highly prevalent problem. I will not say it is a disease, it is the prevalence is very high because it is a normal physiological problem which occurs every month with the females. Findings suggest family history, bleeding duration, and presence of clots as significant risk factors for dysmenorrhea. Appropriate intervention through a change in lifestyle is advised. Yes, very importantly that exercise helps in reducing pain during menstruation as well as reducing the premenstrual symptoms also. And also the intake of high fat containing food, junk food, these all increases the symptoms of dysmenorrhea during premenstrual period. High fatty like junk food is taken, the food which contains high saturated fatty acids and high fat, which is generally the junk food we call it. if the female consumes that kind of food, the severity of pain is more. Whereas wherever when the girls they are advised to cut down on that kind of food during premenstrual period, the intensity of pain is reduced. The barriers to seek medical attention by dysmenoric females needs exploration. Yes, very, very importantly, because many a times the girls, they don't seek medical advice. They tend to hide their symptoms in the fear of, they may be judged, they may be labeled, especially the girls, young girls who are working. They think that if I tell to my employer or if I tell to my colleagues that I'm in trouble, they may judge me. So they try to hide their problems, and sometimes they lead to this hiding of problems may lead to a problem if this patient is having some kind of dysmenorrhea which has got other etiology than primary dysmenorrhea like endometriosis, adenomyosis. So we should encourage all the females to seek medical advice, medical help if they experience pain, which is actually severe enough to interrupt their day-to-day activities. It is very important that health education on puberty and menstruation is regarded as it should be given in schools, all this kind of education which is pertaining to menstrual hygiene, menstrual problem. Ignorance might lead to some serious impact on their reproductive health. Thank you very much for your patient hearing.
Thank you for giving your important information on this topic, ma'am. So let me read out the questions that we got from the participants in the comment box, ma'am. So what are the challenges with current treatment for primary dysmenorrhea?
The most important challenge is that we don't have very good medications which can be taken, because this is a problem which will occur every month. So as I told you in my presentation, that if a patient is a female is taking NSAIDs every month, it may lead to gastritis, gastric ulcers, and if she is already prone to having this kind of problems, she may lead to even sometimes GI bleed also. So this is the challenge, that we don't have very good medications to treat a problem which occurs every month in a female. So this is I think this is a new drug which has come with so many good ingredients like bromelain, all these ingredients which are we can say herbal ingredients and which don't have any side effect. So this is a very good product which has come up, and I think we are yet to test this product in our Indian market.
And another question, ma'am, does pain intensity get reduced after first delivery?
Yeah. Most of the time, the after first vaginal delivery, the pain intensity definitely gets reduced, because this is a cramping pain. So it is due to uterine contraction. So once after delivery, the cervix gets dilated, and after the cervical dilatation, the flow of blood through cervix becomes little easier. So the pain, that contraction is less. The pain intensity of dysmenorrhea is less.
Only 2 questions were there, ma'am, which you have answered. And I thank you for giving so much time and get connected with Shield. I hope we connect more and more times in future for more informative topics. So we can end this session, ma'am.
Yes, thank you very much.
I
thank you
all participants who attended this session. And I also thank you, ma'am.
Okay.